So how do we use patient risk factors? Eric, you want to?
Yeah, so in moving forward, we have these broad categories, and especially with moderate and metagenic chemotherapy where the range is from 30 to 90%. So how do we stratify those patients within that group? And so we've been talking about individual risk factors, and Dawn has mentioned some. So young women, which is usually less than 50, who have a history of motion sickness, low alcohol intake. This is one time where alcohol is helpful. And then women who had a lot of nausea and vomiting with pregnancy. But by far the most important risk factor, and I think which is highlighting what our entire discussion is, if you had CINV in your first cycle, you are 4 to 5 times more likely to have CINV in subsequent cycles. So if you were to try to focus your attention on finding a time to call patients and see how things went, it's after that first cycle.
And that stresses the importance of optimal prophylaxis
Yes.
before cycle 1, and we're going to talk about the drugs, but it's so critical. We shouldn't have to wait. Unfortunately, some payers use something called step therapy, which basically mandates that patients should get sick before they get the optimal regimen, and I'm very much against that. I don't think that's an appropriate approach when we know so much about this field. And we want to prevent it from day one. And to your point about anticipatory, my experience, most of the anticipatory nausea comes after the patient has had the first bad episode. And then when they come in, they trigger. And you know, I've learned to not get too upset when the patient throws up at the sight of me. I assume it's just an effect, but who knows? But from their chemo. So how do you all use patient risk factors? So how do you integrate them? We were talking earlier about putting together guidelines and pathways and then giving our nurses the latitude to adjust those. How do you all do that in your practices with patient risk factors? Do you have a formal way of looking at them at the beginning?
Absolutely. I can bring this back to my clinic yesterday. I started a 46-year-old female with lung cancer yesterday on pemetrexed and carboplatin and an immunotherapy. And you know, and she's clearly anxious. She's sitting there somewhat shaking in my office. So anxiety, female, 46 years old. She's screaming for the best prophylactic antiemetic regimen I can give her. Even when carboplatin was considered moderately emetogenic, I still would have given her every medication, hit every pathway of anti-nausea for this high-risk patient. So it's, you know, it's very easy to have a patient right in front of you that you want to look at those risk factors, and you can just, you know, right away.
Beth, do you find that when you give the more aggressive prophylaxis at first, that then you can back off with subsequent cycles?
Absolutely. And, you know, again, backing off in subsequent cycles probably wouldn't that often unless they were having some sort of toxicity from the actual antiemetic. But boy, if something's working and somebody's feeling well, I certainly rarely would back off. Probably the steroid is the #1 thing I back off on, because that's probably the most toxic out of a triple drug regimen.
One of the nice, oh, sorry.
Go ahead, no. I was just gonna say, you know, that and, you know, always bringing it back to home. What if that was your family member or you? You would want the best drugs that we have possible to give to a patient. And I think one of the things that is probably most important to think about is our clinical experience. You know, you get these young testicular patients, they don't really hit a lot of the well-known risk factors, but I tell you what, in my 15 years of experience, those guys tend to do pretty poorly, and they're getting a very big, you know, heavy doses of chemotherapy. So I think those guys, even though they don't hit the traditional risk factors, tend to do worse than we would expect.
That's a great point. So I'm old enough to remember the era before 5-HT3s, and when I was a fellow looking at patients in the GU clinic who were getting combination chemotherapy, it was brand new with cisplatin for testicular cancer patients, a curative disease 30 years ago, which was amazing. After one dose of cisplatin with no effective antiemetics, these young men came in and said, I'm not taking any more chemo. And our job as the fellow was to sit there and spend an hour convincing them to take cycle 2, 3, and 4. And it was not an easy challenge at all. So it's a great point.